好，那个中文的 section 结束，要进入英文的，大家赶快醒过来哈。Okay, so Dr. Shaunak is on the line. Okay, can you see us?
Yes.
Okay. I'm Dr. Wu Yanwen from Far Eastern Memorial Hospital. It's my pleasure to introduce the next distinguished speaker. And in the previous talk, we already overviewed the NET from the functional and clinical implication. Now I would like to introduce the next guest speaker. Dr. Shaunak, he is a nuclear physician at the Royal Free Hospital, and currently her interest is focused on the radionuclide therapy and oncology imaging. So today he will introduce the current evidence and patient selection for PRRT. So that's welcome.
Thank you very much, Chairperson and organizers, for the kind introduction and for the invitation for me to speak at this conference. So I'm a consultant nuclear medicine physician at the Royal Free Hospital in London. And today I'm going to give an overview of the current evidence and patient selection for PRRT. So this is the outline of my talk. I will give a background about Lutathera and evidence for it, and then speak about which patients should be selected for treatment with the Lutathera, then go on to practical aspects in administration, and lastly, I'll speak briefly on aspects about setting up a service, what you need to bear in mind. So firstly, why has PRRT and neuroendocrine tumors come into the spotlight? The reason for this is the licensing of Lutathera, also called lutetium oxodotriotide or lutetium dotatate. And this has been licensed both by the FDA and the European Marketing Authorization in 2017. Lutetium dotatate is a radiation-based therapy that targets the somatostatin receptor. And as I will show in my forthcoming slides, it has a big impact on patient outcomes. So patients who've got progressive disease, no doubt, who are somatostatin receptor expressing, have a good outcome from Lutathera treatment. And this is the first in the line of theranostics agents. It's the archetype for future nuclear medicine therapies that use the same theranostics concept. So what is theranostics in neuroendocrine tumors? So theranostics is a word that is amalgamation of two words about therapy and diagnostics. The key is that the compounds for therapy and diagnostics are the same and that the target is the same. So in neuroendocrine tumors, the target is the somatostatin receptor, as you can see in this cartoon diagram. So this can be targeted by both cold and radio-labeled somatostatin analogs. And this is the cartoon diagram of the radiopeptide. So it's made up of three components. You've got the somatostatin analog, which is the transporter or homing missile. You've got the linker molecule, also called the chelator, and you've got the radionuclide. So to start with, it's the imaging radionuclide for reconnaissance. So this is injected into the patient intravenously, and because majority of well-differentiated nets have a high expression of somatostatin receptors, they become internalized and allows imaging via gamma rays. And we look at the images and see if there's sufficient uptake within the sites of known tumors. If there is sufficient uptake, then this patient can proceed with peptide receptor radionuclide therapy, and we just change the radionuclide to a therapy radionuclide, aka the explosive device. So this is how theranostics works, and neuroendocrine tumor is the archetype, but obviously a lot of newer agents are coming up, for example, for prostate cancer and so forth. So in terms of what therapy radionuclide was used, so there have been three major radionuclides that have been used in the past. Firstly, there was indium, high activity indium DGPA octretide or octriscan was used, and this uses Auger electrons, which has a very short length and wasn't found to be very successful. There was some short-lived symptomatic benefit, but no great benefit in PFS. The next agent that was used was yttrium-labeled peptides, and this was found to be effective. However, it's got a higher energy beta particle than lutetium. However, there was a high degree of renal toxicity in these patients. For example, the study by the group from Basel showed that 10% of patients developed a permanent renal failure in patients with normal kidney function to start with. And lastly, we come to lutetium. So the licensed product, lutetium dotatate, this has a path length of approximately 2 millimeters and is found to be both effective and relatively safe for kidney function. So going on for evidence for Lutathera. So the best set of evidence is the pivotal NETA-1 randomized controlled trial. So this trial is, the primary endpoint of this trial was progression-free survival in inoperable somatostatin receptor positive mid-gut neuroendocrine tumors only, who had progressed under octreotide LAR 30 milligrams. And the two arms were lutetium dotatate or oxalidotriotide plus 30 milligrams of octreotide LAR versus high dose off license octreotide LAR at 60 milligrams. And these were the Kaplan-Meier curves for the progression-free survival. The blue curve is for Lutathera, and the red curve is for the high-dose octreotide LAR. And you can see there's a huge divergence between the two curves. The estimated progression-free survival for Lutathera was 28 months, and that for high-dose octreotide LAR was approximately 8.5 months. And as you would expect, this is statistically significant, with a 79% reduction in the risk of progressive disease in the Lutathera arm. And there was also a benefit in terms of overall response rate of 18% for the Lutathera versus 3% for the octreotide LAR. So to summarize, this study showed a significant benefit for Lutathera in terms of progression-free survival of 28 months versus 8.5 months for octreotide LAR. In terms of overall survival data, so this was interim analysis that has not been followed up after this. At 30 months, you can see the green curve is the Lutathera, while the gray curve is the octreotide LAR. There were less deaths with the Lutathera arm, which was again statistically significant. In terms of safety data, if we go first, if we look at the bottom, blood and lymphatic system disorder, you can see grade 3 or 4 toxicity are extremely low. Thrombocytopenia of 2%, leukopenia 1%, neutropenia 1%, no anemia. Lymphopenia of 9%. We often see this, but it doesn't have any clinical significance. Even with patients with low lymphocytes, don't tend to have any clinical manifestations. Going to the gastrointestinal disorders, grade 3 or 4 gastrointestinal nausea and vomiting was at 7%, but all grade nausea and vomiting was a bit high in terms of 59% and 47%. The reason for this is at the time of this trial, the amino acid solution that was used to protect the kidneys was used a combination of multiple amino acids. So in the UK, for this trial, we used Vamin 18, which had 18 different amino acids, which does cause a lot of nausea and vomiting. Nowadays, most centers around the world use a dedicated 25 gram lysine, 25 gram arginine, and a liter of saline, which has very much lower side effects in terms of nausea and vomiting. And sorry, last thing to say in terms of the renal function from this study, not shown on this slide, but there was no grade 3 or 4 renal failures in up to 96-week follow-up in this group of patients. And this is mirrored by other studies. Dick Queckerboom and studies in Rotterdam have showed less than 1% of patients have permanent renal impairment if you use amino acids and in patients with normal kidney function to start with. And lastly, in terms of data for the quality of life in these patients, there's a follow-up paper from the NETA-1 group by Strasberg and colleagues, published in the Journal of Clinical Oncology, which looked at the quality of life with Lutathera versus high-dose octreotide LAR. And this was the major finding from this group. If we look at this curve, the blue bar is for Lutathera and the red is for the control octreotide LAR. And we're looking at time to deterioration or deterioration-free survival. And you can see there's a much longer time before the global health status deteriorates with Lutathera versus octreotide LAR. In fact, there was a 22.7 month difference in median time to deterioration. So there's no doubt that Lutathera maintains the quality of life for longer. So this is the summary of the PRRT results based on the NETA-1 study and other studies. The NETA-1 showed that lutetium dotatate is superior to octreotide LAR in terms of progression-free survival, overall response rates. And we know from this and other study that in patients that are progressing, stable disease is a good outcome because that can last for a long period of time. Lutathera has a favorable safety profile with low grade 3 or 4 bone marrow toxicities, as I've shown, and low long-term renal toxicity. And Lutathera improves quality of life, both in terms of prolonging time to deterioration and improvement of symptoms, which is shown in terms of pain and diarrhea that were improved with the Lutathera versus the control arm. And following this study and another study of 400 patients by the Rotterdam group, Lutathera was licensed for the following indications. So it's licensed now for unresectable or metastatic, progressive, well-differentiated G1 and G2, somatostatin receptor expressing gastroenteropancreatic neuroendocrine tumors in adults. So both mid-gut and all gastrointestinal as well as pancreas is included in the licensing. Okay, so that's the background of the evidence for Lutathera, but let's go on to patient selection criteria. So key to the patient selection is a dedicated neuroendocrine tumor MDT. If a center is looking to set up a peptide receptor radionuclide therapy service, the first thing that they should do is to have a dedicated neuroendocrine tumor MDT. And they should have a variety of different members. We have the gastroenterologists, endocrinologists, and oncologists, which in general look after the patients and provide medical treatment options in these patients. Then we've got the histopathologists who look at the histology to confirm that this is neuroendocrine tumor and to look at the grade, which makes a difference in treatment selection. Then we have the radiologist who look at tumor dynamics in terms of our patient's progression. Nuclear medicine who provide imaging and therapeutic treatment options in terms of PRRT. And then it's important to have a surgeon in the room to see that there is no surgical option available. If there is a curative surgical option, that should be the first treatment of choice if the patient is medically fit. And an important member of the MDT is the nurse specialist. So the nurse specialist liaises the decision with the patient, and in general, the patients find that they can communicate and express their what is much better with the CNS. So I think the nurse is an important person in the MDT. So this is what should be discussed in MDT. So in terms of this is in terms of selection for PRRT. So in investigation that we need to look at, we need to look at the histology to confirm it's a well-differentiated tumor and look at the grade, and then look at the imaging to confirm that the patient has a progressive disease. And then key, of course, is that the patient has to have somatostatin receptor positivity, which is done on nuclear medicine tests, either octreotide scan, tetrodotoxide scan, or gallium peptide scan. But you also need to look at the patient themselves, look at the functional status, see that they're fit enough to have PRRT, look at their bloods, that they don't have any contraindications like low hematological markers or raised liver markers. And if possible, if just ensure that there's no surgical cure available for the patient, because that should be the first line option. If the patient is unfit for surgery, that is fine. They could go for radionuclide therapy in this instance. So in terms of investigations, histological grading, first of all. So patients with G1 and G2 tumors are patients that could be selected for PRRT. Patients with G3A tumors, so that they are higher proliferative tumors, but still maintaining the well-differentiated behavior. These may also potentially be treated with PRRT, but the patients with higher grade tumors, poorly differentiated, the G3B tumors are not suitable for PRRT. So secondly, in terms of patient selection, there should be evidence of disease progression, because these tumors can be slow growing and it can be years even before there's evidence of progression. So we should have some evidence of progression, be this radiological or clinical progression. In terms of radiology, uh, um, it's easy if you've got radiological progression, then you can go on and treat these patients. But sometimes disease is not all clearly seen on cross-sectional imaging. For example, bone marrow disease or peritoneal disease may not be very clearly seen on cross-sectional imaging, and in those patients, progression on functional imaging, functional somatostatin receptor imaging may be helpful. But as I've said, it's not only radiological progression that we're looking for, even patients who've got symptomatic progression. When I say symptomatic progression, for example, if they've symptomatic with carcinoid syndrome, despite maximum dose SSA, they may be eligible for PRRT, or if you've got significant weight loss in the absence of identifiable source of this. So this is just an example of what I mentioned. Patient who disease was not well seen on cross-sectional imaging, and this patient had symptomatic progression but stable cross-sectional imaging. So we wanted to make sure that the patient did have progressive disease, and we went on to do gallium dotatate PET CT, and these were done a year apart. And although the cross-sectional imaging showed stable disease, you can see the yellow arrows on the two sets of imaging show new foci of peritoneal disease. So this patient has got progressive disease and went on to be treated with PRRT. So what somatostatin receptor uptake is sufficient for PRRT? So this is the scoring system that has been used. This is based on planar octotide scans. So the tumor uptake score of 1 equals less than that of the background liver, for example, in this first image. Equal to that of the background liver is a tumor grade 2 score. Greater than that of the background liver is a grade 3 score, and intense uptake similar to that of the spleen or kidneys is the tumor grade 4 score. So the patient that you want to treat are the grade 3 and the grade 4 score, because they have they're going to have a higher amount of uptake of the radionuclide, and they're going to get higher response rates. You can treat patients with grade 2 uptake, but generally they don't do as well as patients with grade 3 or 4 uptake. So we want to choose those with high uptake, because higher uptake correlates with higher objective response rates. So these are examples of patients that are suitable and not suitable for Lutathera treatment. So on the right, you can see that this patient has got nodal disease in that got faint uptake in the neck, axilla, and mediastinum, and the uptake is less than that of the background liver. This patient is not suitable for PRRT. The correlate of this is the image on the right, where the patient has multifocal sites of disease in the liver, which is of intense uptake, similar to that of the spleen or kidney. So this is grade 4 uptake, and this patient is suitable for PRRT. So in general, we should have at least 90% of sites of disease have uptake greater than that of the background liver, but they should be of a size that can be resolved on the imaging modality that you're using. So if you're using SPECT, for instance, with indium octreotide or tetrotide scan, then you would want the lesion to be more than 15 millimeters to have uptake. If you've got small lesions, for example, 5 millimeters and don't have uptake, doesn't mean that they're not expressing somatostatin receptors. It probably means that they're beyond the resolution of the camera. And we generally use about 10 millimeters for gallium PET imaging. So FDG PET-CT in well-differentiated neuroendocrine tumors is not performed routinely. And when should we perform this in PRRT settings? So obviously, we don't need FDG as a rule to select patients for PRRT. We need somatostatin receptor imaging. But there are some scenarios when you may want to consider having FDG PET-CT. These are for high-grade tumors, for instance, so G2 that have a high grade with a proliferative index, Chi67 of greater than 10%. If they've got fast progression on cross-sectional imaging, maybe within 3 months, to make sure that these patients are not de-differentiating. If you've seen lesions on cross-sectional imaging that don't appear to be positive on the somatostatin receptor imaging, and you suspect that the patient has tumor heterogeneity, and lastly, if you suspect a secondary malignancy, up to 25% of patients can have secondary malignancy, as was shown by Modlin in a paper about 15 years ago. So the interpretation of the FDG PET-CT should be in combination with the somatostatin receptor imaging. So those suitable for PRRT, if you got positivity in all sites of disease, whether or not the FDG positive doesn't matter. So somatostatin receptor positive, FDG positive, and somatostatin receptor positive, FDG negative are suitable. Not suitable if you've got disease that are FDG positive and somatostatin receptor negative. So you can sometimes get heterogeneity where you get a combination of some lesions being somatostatin receptor positive and some lesions being somatostatin receptor positive, negative and FDG positive, and those that is discordant disease because the patient has a heterogeneous tumor population, and this is not suitable for PRRT. Just to give a couple of examples, this is a patient with well-differentiated G2 tumor with the Chi67 of 18%, and this patient had both a gallium dotatate PET-CT and an FDG PET-CT. And on the gallium dotatate PET-CT, you can see intense uptake within the multifocal sites of disease, particularly within the liver. That's only got low-grade uptake on the FDG PET-CT. So this patient is suitable for Lutathera treatment. This patient has got heterogeneity in terms of uptake. You can see the focus in the left supraclavicular fossa. So this is the gallium dotatate on the left and the FDG on the right. In the supraclavicular fossa, there's uptake on the dotatate PET-CT, but no uptake on the FDG PET-CT. However, the liver lesions, they are multifocal liver lesions that are negative on the gallium dotatate PET-CT, but positive on the FDG PET-CT. And these were the lesions that were progressing. So this patient is not a suitable candidate for PRRT because the progressing lesions don't have a somatostatin receptor positivity and are FDG positive, suggesting that they're more aggressive tumors. Okay, so going on to patient related factors for patient selection for PRRT. So we need to look at the performance status of the patient. So the patients need to be reasonably self-caring so that they can look after themselves after treatment and don't give their carers a high radiation dose. So what we look at is for ECOG performance score of 2 or less. So ideally 0 or 1, but in patients with the 2, generally we can cope. They can cope with the restriction periods that are needed. In patients that are borderline fitness status, then we admit them or bring them into the ward to have a nursing assessment to look at their nursing needs, to make sure that they are reasonably fit to have the treatment and to make sure that they are reasonably self-caring. Next, that you need to bear in mind that patients need to stop the long-acting somatostatin analog for at least 4 weeks prior to treatment. And the reason for this is that cold analog can also bind to the somatostatin receptor, which can reduce the uptake of Lutathera and which may reduce effectiveness of the treatment. So this is just for the long-acting analogs. So patients who are on short-acting analog, they should stop that 24 hours prior to PRRT administration. So in terms of blood contraindications, patients with impaired kidney function, so GFR of less than 30 is a contraindication. Less than 50, you should have some caution in this. Most of the data of low renal toxicity is based on patients with GFR of greater than 50. So we personally have treated several patients with GFR between 30 and 50. We just need to have a little more caution in these patients, particularly if they've got a single kidney. We shouldn't treat patients with impaired hematological function if they've got platelets less than 75, neutrophils less than 1, for instance. And also not to treat patients with synthetic hepatic dysfunction. So total bilirubin greater than 3 times the upper limit of normal, or low albumin and raised prothrombin ratio. So if they've got impaired synthetic hepatic dysfunction or impaired hematological function, they shouldn't start PRRT. So going on to practical considerations. So this is the treatment scheduling for Lutathera administration. So the licensed product is based on giving 4 cycles at activity of 7,400 megabecquerels, that's spaced out between 8 to 10 week intervals. So in total, you get approximately 30 gigs of Lutathera within the patient. So cycles can be extended up to 16 weeks if they are hematological toxicity, which have taken a little longer to resolve. So this is the treatment scheduling. And things that you need to be aware of in between cycles is that these are the things that you need to check. So you need to do safety bloods on a monthly basis or more frequency if there's an abnormal result. So this includes a full blood count, a urea and electrolyte, and liver function tests. And we're mostly looking at the hematological function because that tends to be what is reduced in between treatments. Then you need to be aware that you need to review the patient somehow between cycles. So in our institute, most of the reviews are via telephone clinic to make sure the patients are fit and haven't deteriorated following Lutathera. The most common side effect that patients develop is fatigue, and this must be related to the bone marrow toxicity, which is short-lived. And in selected patients who you're not sure about their fitness, you may want to bring them for a face-to-face clinic. We also need to consider scheduling of the long-acting somatostatin analogs. So as I've said, long-acting somatostatin analogs need to be stopped 4 weeks before having the next treatment. So we need to bear that in mind when planning the next treatment cycle. In general, you can usually give 2 further long-acting somatostatin analogs after PRRT if you are keeping them on. A lot of our patients are kept on for symptom control, and we do administer 3 to 4 days after the first cycle, and then 1 month later, and then we schedule the patient to come back at approximately 8 weeks down the line. Consider interim cross-sectional imaging. Most of the time, we don't do cross-sectional imaging between cycles. It's only if you suspect that the patient is progressing. So if you see new sites of disease on the post-therapy imaging, or the patient has got new symptoms, then you may want to consider interval cross-sectional imaging. You need to bear in mind radiation considerations for the patient. So you need to have risk assessments and advice that you give to the patient in terms of day-to-day activities. Patients will always ask about travel, so traveling by train or plane, for instance, using public transport or air transport. When this can be done, it will depend on your local risk assessments. in terms of what sort of radiation dose they have at a specific time period, and also in terms of procedures. There's some patients that need to have procedures in between administration, and we need to know when it's safe for the surgeons to be able to perform this procedure. So the prior risk assessments are important for these radiation considerations. In terms of the administration itself, what you should consider is both patient-related and system-related issues. So patient-related, as I've mentioned, vomiting and can occur, and you should have a process for this. So all patients should have antiemetics prior to starting the amino acids. So half an hour prior to starting the amino acids, and usually start the procedure half an hour after the amino acids have started. Despite the antiemetic, we usually use ondansetron. In a small percentage of patients, they may vomit, so you want to be prepared with having top-up antiemetics available and a sick ball also available. In terms of carcinoid crisis, if you select the right patient, you're not going to have carcinoid crisis. It's not like with anesthetic where you can get a carcinoid crisis, or if you do embolization, so more invasive procedures, you can get carcinoid crisis. If a patient is in active crisis at the moment, we should delay the treatment until that is controlled with analogs in the first instance. So it's very rare to get a carcinoid crisis during the administration. You can sometimes get a tumor lysis effect, but that is usually delayed after a treatment, maybe a day to two after treatment, and you should just be aware that it's something that can happen. But in terms of the immediate administration consideration, vomiting is usually the only major concern. In terms of the system-related problems, you need to know your pump and your system that you're administering really well. Things that can sometimes go wrong, you should have contingency plans for that. For example, if the patient doesn't have a good line, then you may get increased pressure in the vial, which may cause that to overflow. So you should have a backup procedure if the patient doesn't have a good line and there's a problem with this. As long as you've got that in mind, then an unexpected problem becomes something that you can routinely take care of. In terms of imaging follow-up, so this is our protocol for imaging follow-up. We do cross-sectional imaging 3 to 6 months after completion of PRRT. Usually for us, it's 3 months, and then again at 6 months, and then a 6-monthly interval thereafter. In terms of somatostatin receptor imaging, we don't perform this in all patients. It's because we don't have enough capacity for this. But in some patients, we perform this at 6 months. Wherever possible, we try to do that at 6 months after the end of PRRT. And as I mentioned before, it's not our practice to do interim cross-sectional imaging unless we suspect that the patient may be progressing. For example, if they've got symptomatic deterioration, or if we have new findings on post-therapy imaging. For example, if we see a new liver met or new bone metastasis on interim post-therapy imaging, then we'll do cross-section imaging to confirm this and to confirm whether we need to stop Lutathera treatment. This is only in a minority of patients that this happens. And lastly, I'd like to end with this in terms of steps in setting up a PRRT service. I know in Taipei, for instance, you all are in the process. There are some units that are looking to set up a PRRT service, and this is the things that you need to keep in mind. So first and foremost, I think you need to establish a multidisciplinary net meeting where patients can be discussed, so you can choose the most suitable patient for PRRT. To start with, you should try to choose a patient where is not too unwell or is not progressing too quickly, so that you get yourself used to the system. Things that you need to bear in mind are that you need to have ready before you start country-specific regulations. So you need to have licenses for radiation holding and waste disposal for lutetium. If you don't already have that need to be applied for. Then you need to have risk assessments for radiation exposure, both for the staff during the procedure and for the general public, so the comforters and carers and other general public people. And this usually involves having a document that you give the patient to tell them what they can and can't do. For example, they may want to refrain from spending time with children or pregnant ladies for a couple of weeks, sleep in a separate room from their partner, again for 2 weeks, which is our protocol. You should have set up your prior risk assessment and contingency plans. For example, if the patient becomes unwell, which is not very usual, but if it does happen and the patient needs intervention, like there's a cardiac arrest, you should have a risk assessment for all of this ready for you. In terms of infrastructure, you need to make sure that your building conforms where you're going to treat the patient in terms of the low radiation dose to staff. And one thing that you need to keep in mind is urinary waste. So with Lutathera, approximately 50% of activity is excreted through the urine. So you need to know where the urine is going, and you need to look at your regulations, how you handle this, whether you put this in a tank, whether this can go straight down the pipes, is something that should be borne in mind. Staff training is important, so that staff are confident when administering the procedure. And lastly, you need to have all your standard operating procedures up to date before starting a PRRT service, because there is a lot that goes on in setting up the service. I'd like to thank you for your attention, and that's it from me. I'm happy to take questions.
Really, thanks for your excellent talk, Dr. Shaunak. Give us a talk very comprehensive from the initially we had to set up the MDT, and then including the regulation, infrastructure, and the follow-up protocol. Is any question from our audience? I think it's a very excellent chance to raise the question, especially in the special moment. Please, Dr. Jen.
Thank you for your very clear and concise talk. And I'm Dr. Chen from National Taiwan University Hospital. And now we are planning to set up a therapeutic unit, probably maybe start next spring. And also, I want to ask that I have been asked by our pharmacy department that the amino acid the infusion can cause hyperkalemia and metabolic acidosis. Have you observed any this kind of side effects during the infusion? And do you need EKG monitor to monitor if this patient has this kind of side effect? The second question is that I noticed that there are a lot of patients that have heterogeneous uptake, both with FDG and significant DOTA-TOC uptake, somatostatin receptor uptake, probably grades 2 to 3. So in this case of patient, do you treat them chemotherapy first, or do you have them have PRRT first? Thank you.
Thank you for your questions. They're both excellent questions. So starting with your first one, hyperkalemia. So you are right, metabolic acidosis and hyperkalemia can occur with the administration of amino acid. This is transient and doesn't have any clinical impact on patients. So we no one routinely monitors patients with ECG. We do make sure that they have a normal potassium to start with. So generally below the upper limit of normal, so below 5 or 5.2, depending on what your labs say, we will treat those patients. If they've got renal impairment, for instance, and a higher potassium, we may want to correct that before treating the patient. But we don't need to monitor the potassium or monitor ECG for these patients, because there's transient raise in potassium that doesn't have any clinical consequences if you've got a normal potassium to start with. Going on to your second question in terms of tumor heterogeneity. So I think what we're looking here is for discordant disease. So if you've got discordant disease, FDG positive, DOTA-TOC or DOTA-TATE negative disease, you don't want to give, and if those tend to be the lesions that progress, because the FGG tend to be the more aggressive tumors, those are the ones progressing on general. You don't want to give PRRT to these patients in the first instance. So what we have done is, like you've suggested, given chemotherapy to stabilize those tumors, and then restage patients at a later stage. And if we see now that there's a change, or maybe that focus is no longer FGG positive or has become stable, then we could consider giving PRRT at that point. But just as you said, we would use a similar formula: give chemo first if there's discordant disease, and then restage later on, and consider PRRT again.
Thank you. Is any other questions? So I would like to ask a very simple question. So we routinely to scan the patient with dual imaging. I mean, every case you screen the FDG PET as well as the SRCs routinely,
No.
or you usually select the high risk patient, or routinely you screen all of them.
So we don't routinely screen everybody. There is some evidence that using FGG in all patients has some prognostic benefit, but in terms of selection for patients, we don't do unless they've got a higher grade tumor. So if they've got a Chi67 maybe greater than 10%, then we will do an FGG once at the start to see if they've got FGG positive disease or not. And otherwise, it's for the lower grade tumors, we don't do it. We on follow-up, if patients develop maybe a disease that is becoming very quickly progressing, then we may think, is this patient de-differentiating, and at this point consider doing an FGG PET CT. So to summarize, not FGG for everybody, maybe everybody greater than Chi67 10%, or if something has changed in the patient's tumor where we think that they've got de-differentiation of disease.
Thank you. Is any other questions? No. I think today is a very special chance that we had that connection with English UK, and present most of the hospital in Taiwan just try to start this therapy. I think if we have the more experience, we can have a much deeper talk in the future. Thank you and welcome. Hope maybe next year you have the chance to come to Taipei to enjoy our talk. Thank you.
Thank you very much. And I'd just like to say I'm happy to support any unit that want to ask me a question on a one-to-one basis when they're setting up. I'm happy to support that. Thank you very much again.
Thank you. 那我们这个 section 就到这边很顺利的结束。